Welcome back, everybody. We're going to jump right in to try to stay on schedule. We run a tight ship here, but I'm really pleased to introduce our next speaker, who's going to be speaking about neuropathy, a really hot topic that we commonly have on our forums and on the HPP and Me platform. And I'm really pleased to introduce Dr. Dorn. Following her medicine studies at the RWTH Aachen University, Micah Dorn received a 5-year training in neurology at the University Hospital in Aachen, Germany. Since 2011, she's developed a clinical and scientific focus on rare neuromuscular diseases at the Neuromuscular Center in Aachen. Despite being one of the youngest researchers in the field, she's already received funding and scholarships from organizations and has won several awards, including one for rare diseases. Currently, she is a research scholar at Professor Stefan Zuckner's group at the John P. Hussman Institute for Human Genomics at the University of Miami. So it's my pleasure to welcome you, Dr. Dorn. Thank you so much for coming, and we're really excited to hear from you all about neuropathy during your presentation.
Thank you so much for inviting me. Thank you for the very kind introduction, Deb. I feel very honored to be here today and pleased, and I'm super curious about this whole topic. I've just heard the 2 presentations of my previous speakers, so I'm really happy that you already have a lot of knowledge and that we can discuss a lot more now. My presentation will be focused on neuropathies. So a little bit of a different focus, I think, but I hope this will bring some spice into our discussions, and I'm really, really happy to share my thoughts and of course to hear your thoughts on this topic too. So I hope you can all see my screen and you can hear me well. If not, please give me a sign and then I will maybe give you a short overview on what I'm going to be talking about today. First of all, I'd like to introduce myself a little bit. You've heard some of my background already, but that were only the very formal milestones in my career. I'd like you to get me to know you a little bit better. And then we will talk about neuropathy. So what are neuropathies? What symptoms do they cause? If I see a neurologist, what examinations will be performed? What tests will be done to find the diagnosis and the cause? What role do genetics play? And then a very interesting part that we might discuss further, is it likely that ALPL mutations cause neuropathy? And if so, why? So then the last thing will be more like an outline or maybe a brainstorming invitation for all of us to think about how could we investigate the presence of neuropathy in patients with hyperphosphatasia in the future. So please feel free to ask questions, to discuss further. I'm really, really happy to hear your opinions on all of this. So this is my hometown. This is Aachen. I'm from Germany. It used to be the center of Europe in Middle Ages. So we have a very old cathedral. We have a very old town hall. It's a small city. So, but if you happen to get the chance to come to Germany, I would definitely invite you to come to Aachen as well. So despite the very old city center that we have, and we have a very, very modern hospital. It's actually the biggest hospital building in Europe. And our hospital has an important focus on neuroscience. So this was why I decided to study there. And this was also why I decided to work there. So this is part of my previous work, my group. I had 4 very talented PhD students that worked with me. You can see them here on some of these pictures, very young and driven, nice girls here. And here we were all together at a conference and presented our work. And this is a collaborator from another German city that is called Tübingen, and these 2 are from Tübingen as well. And here we met at the International European Academy of Neurology in Lisbon. This is one of my mentors, Professor Teresa Coelho from Porto. She's very, very, very inspiring for me. And this was a meeting in Japan that she brought me to. Now I am in Miami, you've heard that. So this is my current mentor, Stefan Züchner. He's amazing. He's one of the leading geneticists in the field of neuropathies. And this is where we work, like my building now. This is where we don't work, of course, but where we like to go on the weekends. So for me, it was quite difficult. Actually, you can see it on this picture too, because I have just arrived 5 days before the country was shut down. It was a very, very difficult time at the beginning, so I got to know my group, my collaborators in Zoom, actually, in the first 4 months. That was really hard. But now, as you can see, we keep getting together again. We are working in the lab again. I'm really, really happy to show you my colleagues here that are very driven. And we are a very international group, so that is a very inspiring field. I'm really, really thankful to be here. So now let's get into the topic. What are polyneuropathies? The term polyneuropathy, first of all, comes from Greek. So there's the word neuro, that means nerve, then pathy, that means disease, and poly, that means many. So together, this term means disease of many nerves. It's quite simple. You just need to know the terminology. A little bit more background on the anatomy. So the nervous system has two parts. One part is the central nervous system here that consists of the brain and the spinal cord. And here on the picture, you can see that this is not quite covering everything, because the information that comes from the brain or that has to go to the brain also needs to be connected to your arms and legs and your entire body, basically. So this is done by the peripheral nervous system. Here you have the nerve roots that come from the spinal cord, and then finally you have these long nerves. And now that we have started with anatomy, I'd like to go a little deeper and show you some cellular anatomy as well, because what is so interesting about these nerves is that these cell bodies are very, very long. So a nerve has 3 different parts. This here is the cell body itself. It's quite close here to the spinal cord. But then you have this part here, the dendrites, that receive the information that needs to be transported somewhere. And then you have the long part here that is called axon. And for the leg nerves, for example, these axons can be longer than 1 meter. So these are amazingly long cells. And then here they have their endings, and this is where the axons communicate, for example, with the skin to receive information about pain or any other type of sensation, and also communicate with the muscles. So this is a healthy axon. And then we have these 2 graphs that show how a nerve can be damaged. This is an amazing schematic that is done by my colleague Stephen Scherer from University of Pennsylvania. And you can see here that there are 2 different types, demyelinating neuropathies and axonal. What does that mean? This here is a myelin sheet. That means that's basically an isolation layer for the nerves. You can imagine a nerve more or less functioning like a cable that conducts an electric signal from one point to the other. So if the cable is damaged, you have this. It's axonal, so the information won't get through. If the cable itself is intact, but only the isolation layer is damaged, then this is what happens. So this actually looks quite different because some of the information still gets through, but with a lot of delay. So it's important for us to understand the underlying mechanisms of neuropathies, because that's how we try to target the causes and to treat these neuropathies. So what symptoms do neuropathies cause? This might be interesting for you, because I've heard from one of the previous talks that neuropathy is a subject, is something that is interesting in hyperphosphatasia. So one of you might find themselves here in these descriptions. So we have sensory symptoms. That means all symptoms that are related to sensation. We divide these into sensory plus symptoms that can be pins and needles or the perception of ants running over your skin. And it can also be pain, like burning, stabbing, electrifying. So very unpleasant experience. These sensations are typically located at the skin or right underneath the skin. So it's a very, very superficial thing. And that is called neuropathic pain. Other pain types like muscle pain, joint pain, bone pain are not considered neuropathic pain. It's a different type of pain. So it's very important for us, going back to anatomy, to distinguish where a pain type is coming from, because then we can direct and hopefully also target the causes. And there are sensory minus symptoms that can be numbness, the feeling of socks and mittens, insensitivity to pain, heat, cold, or sharpness, or even gait unsteadiness in the dark or at uneven floors. these symptoms can be more subtle. Sometimes it's even necessary that we examine these symptoms actively, because you might not really notice that you feel less than you might normally feel. So typically, I hear my patients frequently complain of pain, but not so much of numbness. Then there are motor symptoms. I've shown you some pictures here. These are actual pictures from my practice. You've heard I've worked in the neurology department of my hospital for 5 years, and my focus was always neuromuscular patients. So most of the pictures I'm showing you in this presentation are my own. So you can have muscle weakness, or you can have muscle atrophies. That means thinner muscles. And this is an example here. You see these very, very thin calves. And you also see that here, the intrinsic foot muscles are almost all gone. And you can also have muscle cramps. Here in this picture, the patient tries to push with his foot against this device that we have, and we can measure his strength with it. It looks a little dangerous, but it's actually very harmless, this device. It just helps us to objectify muscle strength. So this is another aspect of it, because we always have to ask not only what a symptom is, but how a symptom becomes relative in daily life. So muscle weakness can cause several problems. For example, if you have weakness of the foot elevators, this can result in foot drop. So patients complain of tripping, twisting, stumbling, falls, and also the inability to walk on heels or tiptoes. Leg muscle weakness in general can cause inability to walk stairs, to run, or to jump, or to get up from a chair, for example. And if the hands are affected, you can have impaired fine motor skills. So that can cause, for example, problems to open bottles, or to do buttons or zippers, to eat with cutlery, or to do your hair, or to use a pencil. So that can be very different. Here you see a picture of a patient with foot drop, and here you can see someone who uses a specialized device to improve fine motor skills. So then there are autonomic symptoms. These can also be very variable. So many patients complain of dry eyes or dry mouth. They say that their sweating is disturbed, so that can be more sweating than normal or less sweating than normal. Gastrointestinal symptoms can be diarrhea, obstipation, early satiety, vomiting, so very, very different types that are possible here. And especially in upright positions, some patients complain of dizziness. Of course, you never have to have all these symptoms to qualify for the diagnosis of neuropathy. So neuropathies are very heterogeneous, and some patients only have one symptom or two and not the whole picture, of course. So if you see a neurologist, what do you have to expect in terms of examinations? So this is what I've been doing for many years now. I'm just going to show you how I would have done it in my practice. You know that I've been working clinically in Germany, and here I'm working as a researcher, so I'm not seeing patients myself here in the US. I'm collaborating with many clinicians, but just to tell you that my point of view might be a little bit more focused on how we do it in Germany, but I know talking with my colleagues that most of things are really, really similar here in the US. So the first thing, if you see a neurologist, will be that he or she might ask you a lot of questions. And this is definitely not to annoy you, but to figure out what the lesion of the nerves might come from. And usually what we use in clinic a lot to objectify these questions that we ask and the answers that we get, we use a lot of questionnaires. So I've brought you here 3 different examples of questionnaires here. This is the MGH Small Fiber Neuropathy Symptom Survey that has been developed by my dear colleague Anne-Louise Oaklander, who's also very interested in hyperphosphatasia. She's working at the Harvard University. And here we have the overall neuropathy limitation scale that is used internationally in all types of neuromuscular outpatient clinics that just ask these things that I've just mentioned. For example, are you able to turn a key in a lock? Are you able to use a knife or to do buttons or zippers? And then we have special pain questionnaire here. It's called Pain Detect. It has been developed by my German colleagues who are using it a lot in clinical practice because it's very easy to answer and gives you a very precise estimation whether pain is neuropathic or not. Then we do a clinical examination. That is really, really important for us to figure out what is wrong with the nerves. And here you can see some very practical pictures. At this moment, I am testing the patient's coordination. So I'm asking the patient to follow my finger while I'm moving it. Here I'm testing muscle strength. So I'm asking the patient to push against my hand so I can evaluate how strong he is in this moment. And this is a typical situation that you have seen testing the deep tenor reflexes. This is our nerve conduction lab that we have, so our neurophysiology lab in Aachen at our hospital. I know that these devices look very similar in every neurological outpatient clinic here in the US as well. So what are we measuring here? You might remember the picture that I've shown you, how a nerve conducts a signal. So what we do is we exploit this mechanism actually, and we put an electrode at one point of the nerve. And of course, we have to know the anatomy of the nerves for that very well. And then we stimulate the same nerve at another point. And the stimulus is electric. So you feel it when you have this test done. It's unpleasant, but it's not painful. So we really make sure that this is not a dangerous range of voltage that we give to that to that nerve. What is really, really useful here is by measuring how a nerve conducts a signal, we do not only see the nerve anatomy, but we see how the nerve works. So we observe the nerve while it is functioning. So this type of examination is really, really valuable to understand what type of damage is underlying in a nerve. So we really, really acknowledge that this is not the most it's not the favorite examination because it's unpleasant, but it's very, very useful and helps us a lot in clinical practice. This test is called quantitative sensory testing. We do it a lot in Germany. I know that here it's not so common, but some labs do it. So you can see several examples how calibrated stimuli are applied to define skin areas. Here, for example, this is a device that changes the temperature that is applied to the skin. It gets too warm and cold. And patients have a button in their hand, and they can always push it whenever they feel any difference in temperature. So this is never to test whether someone can really, really take a lot of heat, but it's more like to figure out what are the limits, like the limitations to feel and to recognize a certain stimulus. Here with this device, we test light touch. So we want to know whether a patient is able to feel a light touch with these sticks, and this is to understand the difference between sharp and non-sharp stimuli. So this is really helpful for us as well to see how a certain nerve functions. This is a skin biopsy. Skin biopsies are a very regular part of neuropathy workup, because the skin contains a lot of nerves, and it is very easy to assess and to examine. So here you can see an example of a healthy skin biopsy. And everything that is here in this light green is healthy nerve. So this is how skin actually looks under the microscope with a certain staining. And you see there are everywhere certain tiny little nerve endings. And these nerve endings are responsible for our perception, especially of pain and temperature. And here we have a patient whose nerves are damaged, especially these small nerve endings in the skin. So the intraepidermal nerve fiber density is significantly reduced. That is what you will find in the reports on these biopsies all the time. So how is such a biopsy obtained? It's a very easy procedure, and the diameter of such a punch biopsy is 3 to 5 millimeters, so very, very small. It's done in a local anesthesia, of course, under sterile conditions. And depending on your wound healing, it might sometimes be required to do a 1-point suture afterwards, but that's not in general the case. So to assess the causes of neuropathy, what blood tests might my doctor perform? So the most frequent causes of neuropathy are diabetes. So this is very, very important to consider. And then there can be other organ dysfunctions, like the kidney insufficiency, problems with the liver or the thyroid. So this has definitely to be assessed with these parameters from blood. Then we also take a look at autoimmune markers, such as these ANA, ANCA, rheumatic factor, anti-CCP. And we also take a look at markers for example, chronic alcohol consumption. We all know that alcohol is definitely poison for nerves. So if you assume you might have neuropathy, I would recommend to definitely not drink too much alcohol, unfortunately, because this is actually, even in small amounts, damaging the nerves. And then, of course, we also take a look at vitamin profiles. What role do genetics play in the assessment of neuropathies? So I'm really, really pleased to know that Dr. Rush has already talked a lot about genetics, so I don't really have to dwell on this a lot. I mean, it's usually my topic to talk about because I'm here as a geneticist. But you already know the terms genetics and genomics. You've heard about next generation sequencing. You've heard about variants of unknown significance. So of course, you can ask if any of these things are interesting to you at the end of this presentation, but this will be not my focus today. In hereditary neuropathies, we have very similar questions and issues as you have just recently heard about hyperphosphatasia genetics. So there are a lot of known genes that cause neuropathies. This is just an example of what has already been discovered. And I am currently working in the field of trying to find more genes and more causes that are responsible for neuropathies. So every year, more genes are being discovered by people like my group and others, of course, all around the world. So we are definitely not yet at the point that we can say that we understand every single cause of neuropathy or every single mechanism that leads to neuropathy so far. And this is just an example of one gene that is very frequently mutated in hereditary neuropathies. The gene's name is mitofusin 2, and here you can see as an example where all the different types of variants are distributed. So even if you know the underlying gene, you still have a lot of different options what variants can cause it. And then there are different types of variants. So it's actually quite complicated and therefore also very, very interesting to evaluate the genetics of neuropathies. This is a data set that we see when we evaluate genetics and genomics, actually. So I'd just like to share it with you that you get an impression how this actually looks, because your DNA is just a code with 4 different letters. And this is how it can look here. And you have different reads of this. So it's actually read by our pipelines. And in this case, you can see that at this position here, there are 2 different reads. So there must be a mutation. Something is odd. And you can see that instead of a G, there's at some positions suddenly a T coming up. And that is how we find there's something odd. And then we can try to interpret these variants. So now let's come to a very, very interesting topic. And I have to say that all of the things that I will mention now are quite speculative right now. You have heard a lot from true hyperphosphatasia experts here. So I definitely acknowledge that I'm new to that field. I know a lot about neuropathies, but I don't know so much about hyperphosphatasia. So I'm really, really happy to learn more from all of you. But I've, of course, taken a look at the literature, and I think this is a very, very interesting thought. So let's discuss a little bit and brainstorm together. So we know that vitamin B6 is crucial in neurology. This is something I can really say because as a neurologist, this is definitely solid ground for me. I know that. So I'm always starting from things I know, and then I try to investigate deeper on things that seem plausible to me. So first of all, we know that lack of vitamin B6 in the brain can cause seizures. And this has already been described in hyperphosphatasia. So that's a very interesting thing. Apparently, vitamin B6 can be reduced in the central nervous system. On the other hand, we know also from the literature, this is a very old paper by Michael White from 1985, if I recall it correctly. We also know that peripheral vitamin B6 levels in plasma can be elevated. So this is something that is really interesting. And as a neurologist, I wonder, how might this be connected to certain neurological syndromes? So a little bit of pathophysiology here. If you want to hear more on this, I have found an amazing talk by Dr. Rush on your homepage, actually, on the Softbone homepage, that explains this in much, much more detail. But that is really inspiring, actually. So we know that the brain is protected by basically a wall that is called blood-brain barrier. And it's formed by several different types of cells. And this barrier is very selective. So only very specific substances can cross and can go into the central nervous system, which is very useful because this protects our brain from a lot of different potentially toxic substances that are in our blood. So then here we can see the different vitamins of vitamin B6, pyridoxine, pyridoxal, and pyridoxamine, like 3 different versions. And then here on this side, you can always see a phosphated version here. So a phosphate residue is basically added. So the enzyme that is adding this phosphate to one of these vitamins is called kinase. And the enzyme that removes this phosphate is phosphatase. So ALPL encodes such a phosphatase, and we know that the alkalic phosphatase is relevant here for dephosphorylating these versions. Where's my cursor? These versions of vitamin B6. And this is crucial because with this phosphate added to the vitamin, these vitamins are not able to cross the blood-brain barrier. Without the phosphate, they are. So if you think about this, there might be a reduced function of the phosphatase due to certain genetic mutations, and that causes a disbalance, basically. So there are more phosphorylated versions of vitamin B6 present and less dephosphorylated. So not enough can cross over to the brain. So there's a lack of vitamin B6. And on the other hand, you have too much of it in serum. And this is actually exactly what we have seen here in these publications. So very, very interesting thought. So now, how is this related with neuropathy? Because right now we are not talking about epilepsy, as in the previous paper, but we are talking about neuropathy. And I found several papers. This first one here from 1983, published in the New England Journal of Medicine, so a very, very, very well-known source. And then I found several more case reports. I think this one is from 1993, and then we have more recent ones here. So there are several cases described in the literature that show that too much vitamin B6 can cause neuropathy. So it can damage the nerves. And this is very interesting to consider because vitamin B6 is an essential cofactor in many metabolic pathways, but also in the synthesis of neurotransmitters. So the way how nerves communicate with each other is via these transmitters. So we assume that by disturbances in the synthesis of these neurotransmitters, nerves get overexcited and thereby exhausted and damaged. And that's an idea how this could work. So we know that vitamin B6 is essential. We know that ALPL is involved in vitamin B6 metabolism. We know that reduced ALPL function might result in increased vitamin B6 levels in serum. We know that sensory neurons have their cell bodies in dorsal root ganglia, which is an anatomic structure that is not protected by the blood-brain barrier. And now that is a very interesting thought. And I have to admit, this is just speculative, but maybe we can discuss whether you can follow me until this point. We know that vitamin B6 abundance can cause neuropathy. So why shouldn't be this a potential mechanism that could interlink hyperphosphatasia with neuropathy? I'm just thinking, and I think we should definitely investigate this. So how could we investigate the presence of neuropathy in people like you, patients with hyperphosphatasia? I think it would be very, very crucial to systematically assess symptoms. So if any of you feels like, the symptoms that she's just described somehow apply for me, I can recognize myself in this, then I think it would really make sense to bring some systematic approach in this and find out like what exact symptoms do you have and what symptoms do you share? Because we know that there are a million of reasons to get a neuropathy. And some people who have neuropathy and hyperphosphatasia just might have double trouble, which is very, very unfortunate, of course. But we need to figure out whether these two diseases are really interlinked with each other. So whether there's a gene-disease relationship between ALPL and neuropathy. So we could also start with reassessing already existing clinical reports. That would be an interesting thought too. And then we would search for patterns and similarities, which is very, very crucial, because if we assume that all of you share one single mechanism, then there might also be similarities in the symptoms and in the clinical patterns. And of course, we would love to measure markers, for example, vitamin B6. So then the question would be, do vitamin B6 levels really correlate with symptom severity, for example? And then we would also have the opportunity to compare between affected and unaffected family members, because sometimes it might be that there are other genetic reasons, maybe in the same family, that can also give you some vulnerability of your nerves and therefore favor the development of neuropathy. And we would also love, of course, to correlate certain mutations. So some mutations might have a higher risk of causing neuropathy than others. So these are my thoughts. Of course, I'm never alone preparing presentations, preparing my work, preparing my publications. So these are my mentors, and there are many more. And I'm really, really thankful. I have to say, congratulations to the organizers. This is a beautiful meeting. I feel honored to be here today, and I'm really, really happy to have your questions.
Excellent. This is wonderful. What a wealth of knowledge you've given us, and I think it's given us a lot to think about, because for years we've seen so many patients who talk about neuropathy, but yet they haven't had all the clinical testing to be able to have a confirmed diagnosis. So we've been trying to get patients to take that extra step to get the confirmation of the diagnosis, so we could potentially work together with you and Dr. Oaklander and Mass General to really take a deeper look at this potential connection between HPP and neuropathy. So really important for everybody to know what the symptoms are. So many people may not have a diagnosis because they don't even know. They're used to dealing with pain or numbness for so long, they just may not have that diagnosis. So really great information. Lots of questions here, so I'm going to dive right in.
Yes.
Have you ever heard of neuropathy potentially being a cause of brainstem aura migraines? Do you know any connection or what may cause them?
Well, these are two different categories. Of course, as a neurologist, I have been working with all types of neurological diseases, including migraines. What we know, like again, I always have to admit when I speculate and when I think this might be interlinked, but I'm not 100% sure. In neurology, there are many things that we still just don't know. So we know that nerves can regulate the width of blood vessels. And we also know that blood vessels are involved in the pathogenicity of migraines. But, and of course, it sounds likely that there might be a connection between these two hypotheses. but we don't really have proof.
Mhm.
And migraine is not a typical neuropathy symptom. So my answer would be we don't really know.
Okay. Moving on to the next question. Any connection between how connective tissue disorders can impact nerves?
That's a very, very good question. Again, we don't know the answer, but I'm in contact with people, with several patient organizations with Ehlers-Danlos syndrome.
Mhm.
And we are also right now doing a lot of genetic studies in patients with small fiber neuropathies of unknown cause. And we somehow find a correlation. So we think there might be a genetic link between these. At least, like, we don't know whether connective tissue diseases favor the development of neuropathies, or whether neuropathies favor the development of connective tissue disease, or whether these two diseases have a similar risk factor, which could also be the case. So this is still all unknown, but I feel like, to my experience, especially focusing on genetic neuropathies, I think there is a link that might be discovered soon.
Yeah, we have a lot of patients in our patient community who have Ehlers-Danlos, so that's another very interesting component. We have another subset of research that's going on in Ehlers-Danlos, so I may connect you with some of the researchers there as well to understand that HTP connection.
Sure.
Another question: how does B12 affect neuropathy?
B12 is one of the essential vitamins that, if it's lacking, that causes neuropathy. We know that for quite a long time, so we always assess vitamin B12 deficiency, and it can also cause other things like anemia. So it's very important to always consider it in any type of neuropathy. But if you don't have deficiency of vitamin B12, it's also not necessary to supplement it. So it's not a general thing that everyone should supplement it. Something that we might have learned, especially from vitamin B6, is that we can over-supplement. So too much can also be too much. Mm-hmm. So I think it's important, if you think you might have deficiency in certain vitamins, to get that tested and supplement what is lacking, and not randomly supplement everything.
Makes sense. Another question: do you utilize the tilt table and QSART test for dysautonomia? And can small fiber neuropathy improve with enzyme treatment? I don't know if you know the answer to that. And then one more question, that's another part of that. Treatments that are helpful for POTS and other types of dysautonomia.
Well, okay, 3 questions. I will maybe lump the two that affect dysautonomia and assessment. Sure. So in my hospital in Germany, in Aachen, we have a specialized lab for the assessment of disorders of the autonomic nervous system. We are very closely collaborating, so we do a lot of tilt tables, actually, and also QSART. We also do pseudoscan, which is a little quicker and easier to assess sweat. And so that's part of our routine, definitely. Not every patient gets it. First, we ask some questions, and the patients who have certain autonomic symptoms are then further assessed by this. So yes, definitely, it is very important, I think, and for all types of autonomic neuropathies, including small fiber neuropathies. For POTS, I think the most relevant treatments that we have right now are symptomatic, like muscle training, drinking enough, eating a lot of salt to have enough blood volume, actually. And I don't know, so right now I don't know about a causative treatment. And then coming from that to the enzyme replacement or enzyme therapy for small fiber neuropathies, yes, in general, there is the option, but to be able to replace a certain enzyme, you need to know what enzyme is lacking. Mm-hmm. So for small fiber neuropathies, we have one situation where we can actually replace an enzyme, and that is Fabry's disease. The enzyme is called alpha-galactosidase, and we can directly replace it, or we can also give certain medications to stabilize the enzyme and thereby help. So there is this one option, but for all other types of small fiber neuropathies, we do not have such type of enzyme replacement right now. So this is actually what motivates me so much to do research and to find the causes, because identifying the underlying causes is the crucial step before you can develop a pathomechanism targeted treatment approach.
Okay. Peripheral neuropathy damage, is that typically permanent, or can it be reversed?
The nervous system has quite some capacities to regenerate, which is an amazing thing to observe, but it takes a long time. So under ideal circumstances, when everything is perfect, like the individual with the neuropathy doesn't smoke, doesn't drink alcohol, doesn't take any neurotoxic medications, moves, whatever, like all the circumstances are ideal, and of course the underlying cause is fully removed, then a nerve can heal up to 1 millimeter per day. So if you imagine how far your toes are away from your trunk and how long these nerves must be, therefore, I've shown you this anatomy slide on this. This can take quite some time. And so a lot of patience is required if you want to see your nerve regenerate.
Makes sense. Okay. But it is encouraging to hear that. Some patients are posting questions about starting enzyme replacement therapy for hypophosphatasia and seeing neuropathy becoming worse. Some are saying their neuropathy has improved. Any thoughts or comments on those?
That sounds really interesting. For me, I think the crucial step to give a qualified answer to this would first be to actually assess what type of neuropathy is going on there. Like, what is it that you describe? I totally believe there is something, and this is why I'm here. So I definitely think we have to investigate it. But I prefer to have like a scientifically based opinion before I give it. One thing that I have observed a lot when we treat any types of neuropathies is that there are some dynamics in the symptoms. So totally unrelated to hyperphosphatasia, I have seen it several times that when you start treating the cause of neuropathy, at first, especially the sensory plus symptoms might get worse. Why is that? We think that this is because some of the nerves that had already stopped functioning start functioning again. So you feel it more. Like there's something going on and you feel it more. That can be a good sign. But this is just an observation of mine. I cannot say that this is to any extent related to enzyme replacement therapy in hyperphosphatasia.
Okay, that makes sense. I'm going through more questions here. We talked about B12. There's some questions about potentially supplementing with a dephosphorylated B6 so it's able to pass the blood-brain barrier. Is that something you've seen done before? I know that we'd have to do some more research to see whether or not we think it'd be beneficial for HPP patients, but what are your thoughts there?
Yeah, that is in principle a good idea. The problem is, and that is a problem that we have a lot in the treatment of any types of hereditary neuropathies. We need to get the substance to the nervous system. And how do we get it there? So even if we give dephosphorylated vitamins, which we do, like when we supplement vitamin B6, it's typical pyridoxine, which is dephosphorylated. The problem is that you have these kinases in your body that keep putting phosphates on it. So it's a dynamic thing. The body doesn't respect you like having supplemented it without a phosphate, but it keeps putting phosphates on it because that's the normal thing. That's what kinases do. So this might be a little more complicated. It is a good approach, but I think we have to be aware of the fact that if you already have too much vitamin B6 in your serum and you keep supplementing it, of course, a little bit more might go to the brain then, but then that again might cause neuropathy because it's not enough on the one side and too much on the other. That's really complicated disbalance.
Yeah, this is an interesting question we get in our patient community quite a bit about the collection of B6 and the appropriate technique, because a lot of patients say they go to labs and they feel that technicians aren't collecting it properly, making sure it's light protected. And they're afraid they're not getting accurate readings of their B6. Have you heard of this, and do you have any advice?
So in general, when we assess the vitamin profile in Aachen, we have a very standardized procedure. So the tubes, whenever a patient comes, we have the tubes prepared beforehand. That really helps to have it all ready. For example, another vitamin that is really complicated to measure is vitamin C. We've done a lot of research on this, so it has to be also light protected. It has to be on ice. It degenerates very quickly. I think the best advice is to have it all ready, like to have a set of tubes that are protected with something against light, and that you don't have to prepare it when the patient is already there. And also, of course, to be in good communication with your lab, like to make sure why you are measuring this and what is the question of interest. I've just, when we started measuring vitamin profiles more frequently, I've talked a lot to our colleagues who really measure it and made sure that we deliver it the best way that we can. And one thing, if you doubt that it is measured appropriately, one thing to control it is to send another sample in parallel from someone has normal levels, for example, so that you do not only send the one sample from the patient in whom you expect an abnormal level, but you also send in parallel, obtain at the same time another sample. It can be a healthy family member, it can be a completely unrelated different patient who's just showing up for blood draw at the same day by chance, or can be even your own sample. So from time to time, we are taking blood samples from colleagues as a control, and then to send these two samples in parallel to the same lab. And if, for example, vitamin B6 levels are both too low, then we know, okay, there must be something wrong. The conditions cannot have been right for the blood draw.
Great. There's also a couple questions about gait changes in terms of properly judging distance or tripping, increased chances of people running into things. Is that typically linked to a signal that there's a neuropathy issue or other nerve disorder?
Yes. We see a lot of gait disorders. Like there are in neurology, there are several different reasons that can cause gait disorders. So of course, completely different diseases are like Parkinson's disease. So gait disorder is quite an unspecific term, but we have been studying gait patterns a lot. So the first thing that we do is ask the patient, what happens to you? Like, are your shoes, does one shoe get old earlier than the other? Do you trip a lot? How often have you been falling last month, last week? When do these falls occur? For example, do you think you're tripping more frequently or your gait is more unstable when it's dark outside or when the floor is uneven? And I've had, for example, I remember one patient with a predominantly sensory neuropathy, very nice guy in his 30s. And he came to me and he said, I'm a very good dancer. Like, I'm a really very good dancer. But now I went out dancing with friends and I was like stumbling all the time on the dance floor. So what happened? So we thought, well, okay, that's exactly what happens on the dance floor. You don't have the light on. Your eyes cannot control the position of your feet. So you don't have this type of compensation. So this is a very typical situation for a neuropathy-related gait disorder. And what we do then, like after talking to the patient, is letting the patient walk. So we ask the person, like as I showed on one of my first slides, we have a straight line on the floor in the hospital. So we ask the patient to balance on that line. We ask to walk on the heels, on the tiptoes. We asked the patient to get up from a chair. We can also measure the time for a certain walking distance. We can measure how many steps a patient can take in 6 minutes. So there are very different types of evaluation that you can do for certain gait patterns, and this is something that we really take under consideration all the time.
Great. Is there a difference in presentation of small fiber neuropathy between patients with high vitamin B6 serum levels and those with deficient vitamin B6 serum levels?
Also, very good question. Interestingly, no, not such a big difference, actually. It's really similar. Mm-hmm. And this is also not 100% understood so far, but we think that the ratio between certain vitamins is more relevant than one level itself. So and vitamin B6 is crucial for the synthesis of GABA. GABA is one inhibiting neurotransmitter. So it's giving the signal to the nerve, calm down, it's all right, like don't exaggerate. This is the signal that is transmitted by GABA. Mm-hmm. And if there's not enough GABA synthesis, the nerves get overexcited, which is like on a short term, maybe not a big problem, but on a long term, this overexcitement is toxic to the nerve. Like it leads to exhaustion, and it eventually leads to also to degeneration of nerves. So the idea is that too much or too little of vitamin B6 disturbs the synthesis of GABA, and this disturbs the excitability of nerves, and this leads to damage of nerves. And eventually, the symptoms that you have when you have small fiber neuropathy result from this damage.
Good. Okay. Does neuropathy put a patient at greater risk for a complex regional pain syndrome after surgery or injury?
Yes. I don't know. I haven't seen studies on this in a while, but I have read a lot about the pathomechanisms and of complex regional pain syndromes, and they are quite similar to small fiber neuropathy. So that there are some shared mechanisms in these two types. And so pathomechanistically, there might be risk. And then another thing that is really important to consider is that any type of chronic pain syndrome puts you somehow, unfortunately, at risk to develop another pain syndrome, which is because our brain has this interesting dynamics to not to get just used to pain, but to put more and more attention to pain over time. So, for example, if you in winter, in Germany, it's getting very cold in winter, very different from Miami. So if you go out in winter, like you were in a warm room and you go outside, you feel the cold a lot. And then when you stay outside for a while, it feels like the cold is getting better, like less. And in pain, we have the opposite mechanism. So the longer we suffer from pain, the more intense we notice it, like because the brain develops a pain memory, and thereby we put more and more emphasis on it. So if we already have a painful neuropathy, we have also a higher risk of getting another chronic pain syndrome.
Well, that's all of our questions for now, Dr. Dorn. Thank you so much. And we are like perfectly on time. So thank you so much. This is great. And, if you continue to have questions, those of you who are watching or who are watching on demand, always feel free to send them directly to us so that we can reach out to Dr. Dorn as a one-off to try to get them answered for you. And we're going to try to package all of this into some sort of a fact sheet as a result and an outcome of this presentation. So I can't thank you enough, Dr. Dorn. I know I saw in the chat, you just opened our eyes to so many new ways of thinking about HPP and things that may be connected that none of us ever knew were connected before. So thank you so much for your time.
You're very welcome. I feel very honored. So nice to meet you all, and I hope we keep in contact.
Well, we're honored to have you, so thank you.
Great.
And for those of you who are attending, we have about a 20-minute break. We're going to start back up at 12:30 Eastern time. So again, grab a bite to eat, maybe grab lunch, grab breakfast, coffee, depending on where you are. And then we'll be sure to visit the lounges and some of the exhibitors, and we'll convene in about 20 minutes. Thank you.